and welcome back for our next module. Here we're continuing our examination of human interactions with the healthcare system by building on our work focused on cardiovascular disease and cancer, and now focusing on chronic pain and other chronic health conditions. First, we'll be addressing chronic pain, which is a good place to start since we all experience some amount and frequency of pain, though we don't all experience chronic pain. First, I'd like you to watch a video to introduce you to the ways pain operate in the nervous system. Next, I'd like you to watch another video to help you better understand the complexity of pain, which are listed below and linked within Blackboard. Hopefully these videos brought to light the complexities and impact of pain, especially since pain is the most common reason people seek medical treatment, and most people experience an average of 3 to 4 different kinds of pain each year. While acute pain is typically short-lived and resolves once tissue damage heals, chronic pain, on the other hand, is long-lasting and is either related to tissue damage that cannot heal, which does not resolve once the tissue does heal, or which is related to an unknown cause or etiology. While some individuals with chronic pain are able to cope with it and continue to function effectively, others are often high utilizers of medical care, especially if their pain is more continuous and is of moderate to severe severity. Research suggests there are approximately 50 million Americans living with chronic pain, and the impact of chronic pain is substantial for the individual and for society. Individuals with chronic pain have a lower quality of life, and this effect can be severe. These individuals have higher rates of completed suicide. They can suffer job loss or reduced income, are less productive even when able to continue working, a loss of about 5 hours a week, and often become more sensitive to minor pain over time. The presence of the chronic pain also commonly has a negative impact on the family and friends of the individual affected. For an example, an individual with chronic pain may have a harder time parenting when the pain is flared up. I know I sometimes have to really rely on my husband on a night when I have a severe migraine. In part because I focus a lot of my clinical work around helping people cope with chronic pain, in part because I find pain so fascinating, and in part because I deal with chronic pain myself in migraine headaches, I want to point out a few things I find noteworthy about pain. First, we're essentially incapable of measuring pain with any real sense of validity. This is in large part because pain is subjective and is not something we can see with our eyes or easily measure with any type of tool or instrument. Some try to measure pain with self-report measures, where individuals choose a number from 1 to 10 or 1 to 100 that they believe represents their current level of pain, or with diaries of pain experiences, or with pain-related questionnaires. However, these measures are inherently subjective and are also often subject to the influence of the environment, mood, or even intentional efforts to lie about pain, such as if someone is seeking pain medication or disability pay. Even if we take these self-reports at face value, what do we validate them against? Do we validate them against behavioral observations of pain behaviors, such as facial grimaces or awkward posture or limping? Do we validate them against some kind of physical assessment, like how far someone can bend or how high they can lift something? What about against physiological measures, like the amount of muscle tension experienced or indicators of autonomic nervous system arousal? Each of these means of trying to measure pain is problematic in its own way, and none of them appear to get at the heart of the experience of pain, which is very problematic for medical providers who have to decide what kind of treatment plan to offer to someone who's complaining of pain. A very interesting and novel approach is currently being researched, which is using functional magnetic imaging resonance, a brain scan, to measure pain. Research suggests that these brain scans can fairly accurately measure the degree of pain one is experiencing, whether or not pain is physical or emotional, and whether a pain medication is working effectively. Another thing I find fascinating about pain is that the experience of pain is so strongly dependent on our brain. For example, some areas of our body are more sensitive than others. Our lips and fingertips are more sensitive than our backs or internal organs, for example. This greater sensitivity is due to the density of sensory neurons in that area of the body and having a greater representation in the somatosensory cortex of the brain. The mapping of the skin in the somatosensory cortex helps explain the phenomenon of phantom limb pain, which occurs when, following the amputation or loss of a limb, false pain sensations are experienced that seem to originate from within the missing limb. This phenomenon is experienced by 65 to 85% of amputees. It's thought this phenomenon occurs because the somatosensory cortex attempts to adapt once a part of the body is removed and gives the somatosensory cortex space previously used by the amputated body part to other parts of the body. However, once this occurs, when pain signals are activated in the body part that has taken over that somatosensory space, they can be misinterpreted as coming from the amputated region of the body. That is fascinating. The last point I want to make about pain is that it is a two-way street. What I mean by this is that pain is not the result of a straight-through sensory channel. While the nociceptors are sending messages up the spinal cord to the brain also controls a, quote, gate, a figurative but not literal gate, that determines how well these messages get through to affect our perception of pain. It appears that the gate, so to speak, closes to some degree, and the experience of pain is reduced due to the presence of serotonin, which of course also impacts upon our experience of mood and energy, sleep, hunger, and sex drive. It appears that a region in the midbrain called the periaqueductal gray, or PAG, can activate a descending neural pathway that uses serotonin to inhibit the perception of pain. The endorphins and enkephalins also reduce our experience of pain. These neurotransmitters are endogenous opioids that are found in nerve endings of cells in the brain and spinal cord that bind to opioid receptors, which are the receptors that opiate drugs also bind to. Just as opiate drugs minimize the perception of pain, so too do the endorphins and enkephalins. In fact, this similarity to our naturally occurring neurotransmitters is actually why opiate drugs work to reduce the perception of pain. Enkephalins seem to work by regulating how much substance P, which is one of the neurotransmitters that is secreted by pain fibers in the spinal cord that sends pain signals to the brain, is released. You may have heard that exercise reduces the experience of pain. This seems to be because it results in the release of endorphins. One thing that's very important to notice about substance P is that it regulates not only pain, but also mood, anxiety, stress, respiratory rhythm, nausea, etc. Thus, pain and distress are integrally and inherently related. This helps explain why experiencing pain is such a negative emotional experience. Pro-inflammatory cytokines, which are proteins produced by the immune system, also play a role in the perception of pain by triggering what we typically describe as the, quote, sickness response. Things like increased fatigue, decreased activity, and higher levels of perceived pain. And in the case of chronic pain, making structures in the spinal cord more sensitive to pain messages. So individuals with chronic pain become more sensitized to pain. They experience pain at lower levels of stimulation. They experience the sickness response, and they have a negative emotional response triggered. Then the experience of stress can actually increase the perception of pain, likely via increased levels of substance P. So pain is a source of distress, definitely, but stress also contributes to our perceptions of pain. Of course, pain serves an adaptive function for us, notifying us when we're experiencing some kind of problematic situation, such as touching a hot oven that's burning our flesh, so we can remove our hand as swiftly as possible. Turning off pain makes survival extremely difficult. So why would we have a mechanism by which the brain would be able to dampen down pain messages for the body? Most researchers believe that turning off pain would be adaptive primarily in life or death situations, in which we may only survive if we can ignore the pain and continue to fight or flee the danger at hand. In fact, the body can experience stress-induced analgesia, which is a stress-related increase in tolerance to pain, presumably mediated by the body's endorphin system, which certainly would provide an advantage for survival. Just as with the other chronic health conditions we've discussed, psychological and social factors can also influence the experience of pain. For example, as people get older, there's a progressive increase in reports of pain and a decrease in tolerance to pain. It's currently unclear whether increased perception of pain is a normal consequence of aging due to, for example, changed levels of certain neurotransmitters like serotonin, or whether it's due to other factors, like having fewer coping resources or being in poorer overall health. We also know gender influences pain. For example, women report more frequent episodes of pain than men, with this gender difference already apparent by adolescence. The most recent research tends to suggest an influence of hormones, as there is a hormonal pattern to some types of pain, and certain analgesics may be more effective for women than for men. Other research suggests the differences in reported pain may be due to how much one accepts or identifies with the traditional gender roles, which suggests that men should be able to tolerate greater amounts of pain. In regard to the question of whether there's a pain-prone personality, we do know that both acute and chronic pain sufferers show elevated scores on measures of certain personality tendencies, which include hysteria, or the tendency to exaggerate symptoms and use emotional behavior to solve problems, and hypochondriasis, or the tendency to be overly concerned about health and to over-report body symptoms as well as depression symptoms. However, a big problem with this research is the question of directionality, as the experience of pain could certainly cause depressed feelings or cause an increasing focus on health problems and bodily symptoms, while on the other hand, having these tendencies may represent a diathesis for developing pain-related problems. We also know that social factors can play a role in the experience of pain. For example, I've had so many veterans tell me that they ignored an injury because of the military culture until the pain became so severe that they could no longer function at all. Certainly our perception of and response to pain is influenced by biological and physical factors, but also by psychological and social factors. While I won't be covering any other specific chronic health conditions in any great detail, I do want to briefly provide an overview of a few other such conditions for illustrative purposes, just to help us better understand some of the things we'll cover later about the impact of having a chronic health condition and the ways health psychology can be used to promote adaptation and coping. While each of these chronic health conditions, from cardiovascular disease to cancer to chronic pain to diabetes and HIV and AIDS, differs in its biological underpinnings and disease processes, as well as some specific risk factors and treatment options, much of what we consider in terms of the impact of chronic illness is shared among them all. The first chronic illness in particular that I'll mention is diabetes. While type 1 diabetes is an autoimmune disease, a disorder of the endocrine system in which the body is unable to produce insulin and is present beginning in childhood, type 2 diabetes, which typically has an adult onset, is a disorder where the body is unable to properly utilize insulin. As we'll discuss more fully in the module focused on food and nutrition, being insulin resistant is a state that can develop over a very long period of time if blood sugar is frequently very high, or where sugar is taken in amounts where it's not able to be absorbed by the cells, and so it's freely circulating in the body for a long period of time, which can damage the regulatory feedback system that tries to maintain homeostasis in terms of blood sugar and metabolism. Type 2 diabetes is typically associated with obesity and is showing earlier and earlier age of average onset. The next chronic illness I'll mention is AIDS, acquired immune deficiency syndrome, which is typically spread from mother to child in birth, between sexual partners, or between individuals sharing blood, such as drug users who are sharing needles. AIDS is a life-threatening disease that's caused by the human immune deficiency virus, or HIV. HIV, in terms of how it works, is actually really an interesting virus. It's called a retrovirus, and what it does is it destroys one type of immune cell in the body by copying its own genetic information onto the DNA of the host cell, so that when the immune cells are activated, because the body needs to fight an antigen, for example, the HIV virus is what is reproduced instead of more immune cells. It sort of takes the immune system cells hostage. Because the immune system is compromised, this leaves individuals with HIV very vulnerable to opportunistic infections, which individuals with normal and developed immune systems almost never get because a healthy immune system is able to effectively fight them off. Individuals don't die from HIV or AIDS itself. They're dying from the infections that they're left vulnerable to because of the presence of HIV. For a period of time after the initial HIV exposure, an individual's immune system is actually able to destroy most of the virus, and symptoms are pretty mild or even non-existent. However, after a latency period, HIV moves into stage 2, and here's where you start to see the concentration of specific immune cells dropping and the concentration of the HIV virus rising. This is accompanied by the types of symptoms that people experience when they get sick. Then people move into stage 3, where the immune system really becomes impaired and opportunistic infections can occur. Finally, individuals move into stage 4, which is where basically almost all of their natural immunity is lost. This is what we would consider full-blown AIDS. A few interesting things to consider about HIV and AIDS. First, HIV is actually less easily transmitted than most other viruses, so there's a very relatively low risk for transmission in comparison to other viruses. However, people who are infected with other sexually transmitted infections are up to 5 times more likely to acquire HIV if they're exposed. Individuals with HIV are also more likely to transmit the virus to others during sexual contact if they're also infected with another sexually transmitted infection. Of course, HIV is so easily preventable in adults simply by engaging in safer sex practices and not sharing needles. I'd like you to listen to this coverage from Radiolab about the true origins of HIV, as it just illustrates so many important things about our health risks, our health policy, and health research and its implications. For quite some time, there was information about the patient zero responsible for the spread of HIV in humans. There are a few sections to the story, but you only need to listen to the section on HIV. It may seem like a long time ago, but it's been up until fairly recently that HIV infections were almost always a fairly rapidly progressive, fatal disease. However, medical treatments for HIV and AIDS have dramatically improved, and we're seeing an increase in individuals over the age of 50 who are diagnosed with HIV, and a definitely increased life expectancy for those who become infected. Because of this, instead of viewing HIV and AIDS as a terminal illness, it now is sharing a lot more similarities with other chronic illnesses. At this point, the average time from becoming infected with HIV to developing full-blown AIDS is about 10 years. The period from being diagnosed with AIDS until actually dying might be as short as several months, or it might be as long as 5 years. So many individuals are living a decade and a half or longer once they're infected. Pretty quickly, this is even continuing to lengthen nearly exponentially, with the HIV virus and AIDS progressing even more slowly among those who have stronger immune systems at baseline. The last specific illness I'd like to talk about is dementia. Remember that I'm not covering all the conditions covered in the book, but I wanted to choose a few to focus on to help illustrate some of the commonalities and differences when facing differing health conditions. Dementia is a loss of brain function that occurs with certain diseases, which affects memory, thinking, language, judgment, and behavior. Alzheimer's disease is one particular type of dementia, but dementia can also stem from other disease processes like stroke, diabetes, or even HIV. Dementia is very common and is a major source of disability worldwide. We're seeing the prevalence of dementia really increasing in our country as the baby boomer generation is growing older and reaching the threshold where dementia is commonly seen. Despite the specific type present, dementia has a huge impact on the individual and also on the family or the individuals the patient is close to. Dementia can be associated with difficulty remembering information, especially forming and retrieving short-term memories like where's my keys or did I lock the door in the beginning, but can progress to the loss of even distant autobiographical memory in later stages, where even close family members like one's spouse or children are not recognized. It can also be associated with things like the ability to understand or use verbal language, poor judgment, and increased distress, which manifest in agitation, irritability, trouble sleeping, and perhaps even paranoia or hallucinations in the later stages, though these behavioral disturbances and distress tend to come and go. As you can imagine, this experience of having one's identity and history fade away, or to go in and out of conscious awareness, just imagine how scary that would be. Dementia is very challenging in terms of personal and family adaptation. When we consider chronic illness, of course, the ideal scenario would be to try to prevent these health conditions from developing in the first place. Again, this is the strategy with the best outcomes. It prevents human suffering, saves money, and has the best return on investment through healthcare policies. The best return on investment, though healthcare policies, unfortunately, often continue to be more short-sighted and do not prioritize prevention. While treatment of conditions once they develop is of course essential, over time the need for active treatment could be reduced with more effective primary prevention. Many of the risk factors for most chronic health conditions are shared. Things like being overweight or obese, having a poor quality diet, not being physically active, and being under stress. For example, there's good research to suggest that stress minimizes the ability of the body to regulate blood sugar. These can be associated with psychosocial factors like being from a lower socioeconomic status or having a lower quality of education, factors which often vary by ethnic group in our country. However, there are some very specific risk factors for certain conditions. As of 2014, the most recent data I could find published, there are about 37 million people living with HIV, with about 2 million new cases each year. 10% of those were children, and there were 16.5 million orphans due to AIDS worldwide in 2010. For HIV, the greatest amount of exposure overall continues to relate to sexual contact, followed by IV drug use, though the specific rates vary by gender and what part of the world you're talking about. Sometimes exposure risk is related to social conditions, such as very limited access to contraception, or the impact of religious beliefs and norms, especially on social or sexual practices. Both knowledge of how and the means to protect oneself are not nearly as available worldwide as in our country. However, even in the presence of the knowledge of how to prevent HIV transmission and access to condoms, and at least in some places also to clean needles, and despite the fact that massive effort has been put into educating people, rates of condom use and other safer sex behaviors are still pretty low. We know that optimistic bias and perceived invincibility are very common. People just don't think that these health problems are going to happen to them. They think they're not going to be affected. We also know that there's a tendency for people in long-term relationships to become kind of complacent. For example, we know that women who are in casual sexual relationships are actually 11 times more likely to engage in safer sex practices than are women who are in more committed relationships. Unfortunately, sometimes there is infidelity, and that could put someone in a committed relationship at risk. And women are more easily infected with HIV in heterosexual contact with an infected partner, and actually progress from HIV to AIDS at a lower viral load, so they get essentially more sick faster. We also know that there are some specific behaviors among subgroups that are problematic. For example, there continues to be a stigma associated with being a drug user, especially an IV drug user. So different groups of IV drug users often form sort of closed, tight-knit communities that have a lot of mutual interactions with one another, which may mean that once the virus enters these communities, the spread can happen really quickly among group members. As another example, there's also some evidence that suggests an association between the spread of HIV in African American men and homosexual sex acts, which some experts actually believe is the leading cause of HIV transmission in this group. There are some such men who are, quote, on the down low, who identify as straight and are often married or in long-term heterosexual relationships, but who regularly engage in homosexual sex acts in secret. We know that about a third of black men who engage in homosexual sex acts are HIV positive, and that 90% are unaware of their status. Here's an article providing some more information about this association, which I think is interesting to consider in terms of risk factors and how to try to engage people in prevention, because it obviously has to go much farther beyond just providing information. Similarly, research shows that many college students admit that they would lie about their sexual history to obtain sex at the present moment. So, it's difficult and potentially dangerous to just take someone's word about their risk status. So this is just my plea to you all to protect yourselves. All right, let's move on then to discussing the ways in which health psychologists or allied professionals can be helpful to individuals diagnosed with a chronic health condition. The first question we must consider is whether a chronic health condition represents a crisis in someone's life. I think that when many of us who have not had a chronic illness think about what it would be like to have cancer or to have diabetes, I think we make the assumption that it would represent a crisis. However, the data doesn't really bear that out. A crisis model for chronic illness is just not very well supported. Data also don't seem to suggest that people go through a process of grieving or stages of coping or adapting to it, where one's response and level of distress related to the chronic condition vary significantly in predictable ways over time. Rather, the most comprehensive examination of how people adapt to chronic illness suggests that really it's a dynamic adjustment process, meaning that it's something that's in flux, that's changing, that's ever evolving, which varies between people and depends a lot on the context in which the illness is experienced. For example, the extent to which you must interact with doctors and other health professionals, the extent to which you experience a perceived loss of control in feeling like one's ability to make their own choices is taken away, the severity of and functional impairment associated with the symptoms experienced, the extent to which one's symptoms can be observed by others, the type of treatment that one must undergo, the relationships one has with their medical providers, whether the patient is a young child or an adult, how much social support one has, one's underlying personality. These are all factors that affect the adjustment demands required and how one is able to meet those demands. Of course, the demands vary from day to day and even moment to moment. The demands required for coping with some illnesses are just going to be higher than for others. For example, it's harder to adjust to cancer than it is to adjust to diabetes in most cases. While having type 2 diabetes can result in symptoms like decreased energy and impaired sexual functioning, and will typically require adopting a more strict regimen of diet and exercise, and perhaps require taking oral medication and/or testing blood sugar and using injectable insulin, diabetes is not perceived to be potentially fatal in the same way that cancer might be. And the treatment for diabetes is much less physically and mentally distressing than our chemotherapy, radiation, and surgery. Prognosis is also a factor to consider when we think about how individuals adjust. For example, while there are medications that can slow down the progression of dementia and help maintain functioning, there currently is no cure. Damage can't be reversed, and dementia is known to be a progressive condition that will continue to lead to deterioration over time in the most key areas of one's identity, personal relationships, and life. Thus, a diagnosis of dementia may be much more distressing than a diagnosis of something like asthma. Or if we compare the experience of having cardiovascular disease with chronic pain. While the implications of different kinds of cardiovascular disease would obviously vary, such as a heart attack versus coronary artery disease, interactions with healthcare professionals around the treatment of CVD is far less distressing than that surrounding chronic pain, which is far more ambiguous and rife for conflict between the patient and medical provider. For pain, the mainstay or first-line approach is the use of pain-relieving drugs, including central-acting opioid drugs and peripherally acting non-opioid drugs. Opiates are drugs that act on receptors in the brain and spinal cord to reduce the intensity of pain messages or the brain's response to pain messages. While these drugs are effective, they're often not recommended for the long-term management of chronic pain because the body becomes tolerant to them over time, meaning they lose their effectiveness. Also, most induce a high or feeling of euphoria or relaxation, which can lead to some degree of psychological dependence, especially if someone has a comorbid psychological condition. And they have side effects of use like severe constipation or cognitive dulling, which is why individuals should not operate machinery while under their influence. This sets up a challenging dilemma for medical professionals, as it can be difficult to try to treat a patient's pain while also trying to avoid creating a new problem of addiction. This is a very serious problem that we as a country are grappling with, as individuals who've become addicted to opioid medications, but who are cut off from this treatment, often turn to heroin or buying even stronger pain medications off the street. While there are other forms of treatment available, such as non-steroidal anti-inflammatory drugs, antidepressant medications, which seem to work through the influence of serotonin on the pain pathways, surgery, physical therapy to increase strength and flexibility, counter irritation to sort of interfere with the transfer of the electrical messages of pain, epidurals to numb the spinal nerves, steroid injections to counteract inflammation, and massage and acupuncture, which can reduce muscle tenderness and sympathetic nervous system activation, the patient often does not find the pain relief from these alternatives to be as complete as with the opioid pain medications, which can lead to difficult negotiations in the doctor's office, or even a patient being deemed to be a, quote, drug seeker, which often means their complaints are no longer taken seriously. In addition, these alternative approaches to treatment are not always risk-free. For example, an individual can experience a lethal overdose on Tylenol. This is especially concerning for individuals with cognitive declines, such as with dementia, who may overtake medication accidentally. Or with surgery, sometimes scar tissue forms that can make pain even worse. Thus, the experience of trying to manage something like cardiovascular disease is typically much less challenging than trying to manage something like chronic pain. Of course, the ways in which we adjust may really change over time. Given the medications that can so effectively be used to manage HIV, as long as the individual has health care and is not being bankrupt by trying to receive effective treatment, the interference caused by having HIV may be relatively minor to moderate in the early stages, though there may be depression and fear as one contemplates future challenges or must deal with changes to social or other circumstances. However, as HIV progresses and turns into AIDS, a number of different bodily symptoms, including the central nervous system, are impacted, and the individual can experience severe illness, confusion, and even personality changes, along with changes in one's important roles and family structures and social, as well as social stigma, which may worsen the more obviously ill they are. Thinking back to how we understood the experience of stress as being a process that relates to both our primary interpretations of whether a given event or circumstance is threatening, as well as our secondary interpretations of whether we have enough resources to cope, this process certainly applies to how we adjust to chronic health conditions as well. Of course, for most chronic health conditions, adjustment really is something that's required of the entire family unit surrounding that patient, whatever that family might look like. As a given individual experiences distress and difficulty functioning and must undergo a treatment process, this is typically not something undergone in isolation. For example, the parents of a child who is ill may have to try to balance the demands of work, marriage, parenting other children, and self-care when trying to care for their child. A husband or wife who has an ill spouse may experience changes in their social interactions, ability to work, financial health, and quality of marital interactions. A child or spouse or parent of a patient with a chronic illness may feel very loving and supportive while also experience a great deal of sadness or even also frustration and anger, all at the same time. Health psychologists can play a big role in helping individuals who are ill cope with their illness more effectively and experience greater quality of life, as well as helping the other parties involved, the important others of the ill individual. One way health psychologists can be helpful is by focusing on the primary interpretive process surrounding the illness, whether the chronic health condition is seen as a threat or not. For example, in the experience of chronic pain, I've often heard patients say they no longer feel like a man if they can't do X, but often have pain flare up after they do it. But they remain unwilling to give up that activity because it relates to their self-image. This belief and the way it interacts with pain can be identified and labeled and then discussed in terms of the patient's overall well-being and functioning. Often interventions focusing on primary interpretations can focus on thought patterns that are ineffective, such as catastrophizing or overestimating the negative impact of an event, fortune telling, where one foresees a specific and negative future that may be out of line with reality, or victimization, where they ignore areas they have agency and control, to help the patient recognize that the experience of being ill may not necessarily be as threatening as they're perceiving it to be. This often involves ensuring the patient has received good psychoeducation, so they have accurate expectations for what their particular illness means in the short term and in the long term, and what the treatment may entail. Interventions focusing on whether an illness is perceived as a threat may also focus on helping individuals use their lives in a meaningful way that is consistent with their priorities and goals, even in the face of illness, or to focus on things one is grateful for. For example, we know that long-term survival of individuals with HIV is associated with factors like keeping an upbeat and accurate, although optimistic and hopeful outlook, and that HIV progresses much more rapidly among individuals who are chronically depressed and those who are pessimistic and hold negative beliefs about themselves. Thus, the impact of thinking and beliefs on health outcomes among those with chronic health conditions is undeniable. Of course, if someone has something related to their illness that's a problem that clearly needs to be addressed, if those things can be directly addressed or solved, problem-focused coping is really the only thing that makes sense. If you can fix the problem, do it, and no threat will remain. One of the ways this might be done is by helping an individual be more compliant with their medical treatment. The compliance with the medical advice patients receive is often quite poor. In adults, it's something like 75% of medical patients who fail to follow at least some aspect of their doctor's advice. A lot of times the reasons for non-compliance are relatively simple. People forget, people underestimate the severity of their illness, people just don't make time. For HIV, patients may fail to follow advice because the treatment regimen is one of the most complicated an individual can have. Taking medications in the morning, middle of the day, and night at different dosages and in different combinations. Often, increasing a patient's compliance with their treatment plan will help their illness be better managed and may make their illness be less of a threat to well-being. Thus, the extent to which the illness disrupts their life functioning is reduced. Alternately, sometimes one of the most important things you can do is help people find new ways to meet old, long-standing needs. For example, if someone has not been able to get a lot of socialization at work and had most of their friendships at work, and they're not working now due to illness, they may be feeling very lonely. Treatment may focus on helping them identify this need and find new ways to meet that need for meaningful social interaction. Of course, sometimes the ways an individual makes sense of his or her own illness is related to how that illness is viewed by the broader society. For example, AIDS was originally perceived as being a disease that only affected homosexual men, and there's been a lot of criticism of the failure to share information or enact public policy to try to reduce the spread of AIDS when it was first identified as a global problem, which is often seen as being due to its stigma. Many of you may remember the case of Ryan White, who was a young guy who had a disease called hemophilia, which is a genetic disease where his blood was not able to clot quickly enough, such that even a minor scrape could be life-threatening. Due to the hemophilia, Ryan had to receive blood transfusions very regularly. And because you can't screen blood for a disease or virus that hasn't been identified yet, Ryan White received blood that contained HIV and became infected. He experienced a huge amount of backlash, where the schools in Indiana where he was living did not want him to attend, and he and his family had a lot of social rejection, prejudice, and discrimination because of the fear surrounding HIV and the fear he'd infect others. I'd like you to watch 2 video clips from a made-for-TV movie about Ryan White to help appreciate the extent to which public perception of one's health status can have a big impact on how threatening to well-being of oneself views it to be. Which is a nice transition to consideration of social support, which is one of the many resources that affect our secondary interpretations and whether an experience is viewed as threatening or harmful, is experienced as stressful or not. Social support has been found in individuals with HIV to make immune cells decline less quickly. It's also been found to be important in coping with other chronic health conditions. Interestingly, social support is a protective factor, even if it's delivered over the internet or through participation in a support group, where individuals from a community of people who are going through the same or similar problems can interact in a supportive manner, perhaps by talking about their experiences, validating one another's emotions, identifying the types of fears they have, or sharing information about treatment and ways to be a better advocate for yourself in the medical system. Psychologists and other mental health professionals can also help patients increase their social support by taking better advantage of the social support they already have, by learning to communicate more effectively about their needs, and helping them ask for the type of help that they would find most beneficial. Psychologists can also use strategies more specifically targeted to the illness at hand. For example, in individuals with dementia, family members are often educated about the importance of helping the patient be more active and stimulated to help maintain cognitive function as much as possible and to help fend off depression. Family members can also be educated in ways of allowing the patient to reminisce about their past in a helpful way and to disengage from arguments in times when the patient is confused or not cooperative. For individuals with chronic pain, interventions may teach patients to utilize pacing, where they learn to space physical activity out over a longer period of time with intermittent breaks for rest and recovery to try to prevent pain flare-ups. For nearly all chronic health conditions, the best outcomes are found when multidisciplinary treatment is offered, where medical treatments are combined with psychological and social ones. Thanks for your time in this module. I hope you feel you learned something new, and I'll look forward to seeing your thoughts in the discussion. I'll be back next module with more information. Take care.